Okay, let's start with the Creating a Culture of Care, Part 1. I'm going to try and do these in 2 parts and keep them as much as I possibly can into 20 or 30 minute increment sets so that they are more manageable to download and to listen to. So we're going to do this in 2 parts. Hopefully I'm somewhere close to that 20 minutes because I'm afraid that maybe it won't even be long enough, but we'll just go and see, and I guess too short is better than too long. So as we start looking at this Creating a Care, let's start looking at healthcare settings. We know that just by having worked in hospitals and been around hospitals and stuff, we know a lot more about hospitals potentially than we do some of the other healthcare settings. And we know hopefully that all healthcare settings are accredited by somebody. It doesn't necessarily have to be the Joint Commission, but there are people who are watching to make sure that regardless of what setting you're working within, that those settings are doing things safely for the patients and for the community. But it's also important to realize that the accrediting bodies have different standards depending on what healthcare setting you work within. So most of us are probably most familiar with the hospital setting as well as the hospital accrediting body requirements. Those requirements do not necessarily cross over into the other settings that we can administer healthcare in. So hopefully some of this is just going to be some kind of repetition for you. There might be a few subtleties that you haven't been aware of in the past, but let's go through real quickly and discuss each one of these different types of settings, knowing that new settings are being created almost on a daily basis, because who would ever think that Walgreens would become a setting where we would give health care, but it is now. So the first and foremost, and obviously the one that hopefully most of us are familiar with, is hospitals where we do acute care health services. This is designed to be a place where people go for just a short period of time. You guys all have heard us talking about how the acuity of illnesses that we're taking care of is increasing, and that's because hospitals are really truly the place where just the sickest of the sick go. We take care of people outside of hospitals for a lot of different things and for a lot of different reasons. Part of that reason is financially driven, but actually part of it is that we've discovered that by the longer we keep somebody in the hospital, the sicker they end up being. And it's kind of one of those phenomenons of which came first, the chicken or the egg. Do we make them sicker by being in the hospital, or are they in the hospital because they are sicker? But we definitely know that there is something, to be said about getting them discharged, that their chance of survival and chance of living a longer life is greater when they're no longer in the hospital. And a big part of that is because we know that, one, we make mistakes in the hospitals, and two, we give people infections in hospitals, so we can hopefully keep them well by getting them out. And so that's created a lot of the other healthcare settings that we now have, which are, the next one we'll talk about is an extended care facility, which is more commonly known for a lot of you all probably as skilled nursing. This is kind of an intermediate care and an extended care, a long-term care facility. They can be located actually within the 4 walls of the hospital or actually on the complex of the hospital, but they can also be freestanding. And then from there you could go to a subacute facility, and this facility provides extensive care to clients who've just been released from the hospital, but they still require some kind of nursing care. And oftentimes it's not necessarily the nursing care as much as the technological savviness or complexity of the equipment that they need to be cared for. So those of you who might be familiar with Rankin Jordan here in St. Louis, which is a pediatric subacute care facility where children who are still intubated and requiring ventilators at nighttime, or at least sometime during the day, they can be discharged to Rankin Jordan, which is still a facility, still a hospital in some aspects. You're still staffed by nurses, it's still requiring nursing care, but it's in a different environment where the children's developmental needs can be met there as well. And then we've got ambulatory care centers, which are your outpatient centers. So this is a lot of diagnostics or one-day surgery, clinic-type care. So it's outside the hospital setting with specialized care. We can do immunizations, primary care, ambulatory care, those types of things are in the outpatient centers. Then obviously we have home health, and this is where we provide health care in the client's home. It's provided by healthcare professionals. It can be a skilled professional like a nurse, or it can be an unlicensed professional like an aide. But it's care that's done in the home. So it's non-medical or custodial care where we can actually help keep them out of the hospital but meet their medical needs in a hopefully better environment. Then you've got retirement and assisted living facilities. These are technically non-institutionalized facilities that are used by people who are not quite able to live on their own, but not in need of constant care. Okay, so they don't really need continuous nursing care, but they need and or desire to have somebody who's kind of around and available to help on them. So there's really no special medical monitoring. nor is there a guarantee of having 24-hour nursing staff. But there's typically trained staff that live on site, or I shouldn't say live on site, that are on site 24/7, who can provide services if they need it. And oftentimes these are individuals who are living in private apartments that are generally somewhat self-contained. They may have a common areas that they can go to, but they still typically have their own individual space. Then we know about hospice services. We know that hospice services are care that we give to clients with a life-limiting illness, and we know that also they can take place in a variety of settings. They can be in the client's home, they can be in a nursing home, they can be in the hospital. But hospice care is really when the family and the patient has made the decision that they are no longer wanting to receive life-extending care, but doesn't mean we're not giving them care. The whole purpose of the care that hospice provides is to provide the best quality of life that we can within the confines of the medical condition that is life-limiting. So there's a lot of focus on pain control and things along those lines, and making sure that the individual and the family is comfortable as possible as they're going through this process. And then psych hospitals are not typically as freestanding as they once were, but we know that psych hospitals is an inpatient facility that specializes in the treatment of a person with a mental illness who needs some kind of emergent or urgent treatment. We know that the funding for this has gone down, and that many psych illnesses are now being treated on an outpatient basis and in the community, with the idea of trying to keep the individual as a part of their normal day-to-day life as possible, and I'm sure somewhat to do with funding aspects too. And there's also actually substance abuse treatment centers, which are going to offer treatment for recovery services for like things like alcohol and drugs. The whole point of the service is to provide activities that are aimed at improving the lives of the people who are affected by alcohol and drug abuse, while ensuring that we're meeting their healthcare needs, but also the psychological needs that recovering addicts are in need of to continue to be functioning members of society. So those are kind of the different healthcare settings that are available to us at this point. And like I said, this is kind of an evolving or changing list as we continue to learn more about some of the pitfalls of some of these different healthcare settings. We create hopefully new ways to meet the needs of the family. And I like this circle of care that I have up there, because it is really honestly a continuum where you kind of go from one to the other. It's not necessarily a straight path, and although I do indicate on here like a clockwise movement, you got to recognize you can also go backwards in that movement. Alright, next let's talk about managed care. And I know that managed care has kind of become a dirty word in healthcare today, and there is a lot of reasons that it's gotten to that point, but we've got to look back at its inception to try and understand what the whole purpose of managed care truly was. And the whole purpose, honestly, was to help control the use of services so the services would be available for those who needed them, and so that they weren't being abused. So, I mean, when you look at the true objectives that managed care had, it was to reduce unnecessary healthcare costs. We used to keep people hospitalized for days and days and days when they absolutely didn't need to, and like I was alluding to earlier, we have discovered that the longer we keep you in the hospital, the sicker you are. So that was part of the motivation for this. We were also trying to just find less costly forms of care. Once upon a blue moon, there was really no consciousness to healthcare, and anything you wanted or kind of thought might help, you kind of got, regardless of whether you needed it, which might then make it to the point where somebody who truly needed that service or care, it wasn't available because we had needlessly used it earlier on. It also was really looking at the medical necessity of specific services. We've gotten into a habit where we order so many tests and procedures just because we can, not necessarily because we need to. And again, there's always going to be potential harm in any service or medication we provide, as well as then we have limited resources, and then those resources wouldn't be available potentially when we did need them. The other real true driving force behind this was trying to kind of establish a cost-sharing incentive so that physicians were going to take some ownership or responsibility in being more wise stewards of the resources that were available to them. It didn't always work out necessarily in that aspect, but that was a lot of the reasons why managed care was truly first started, was just to help use our resources wisely to make sure that we weren't unknowingly harming our patients by doing things needlessly to them, and it really kind of trying to be a conscious, thinking twice before you did something. Don't just do something because we've always done it, or do something because it's available. And the way that they were hoping to Work managed care was the creation of these different organizations, and I'm certain that you're fairly familiar with these or have at least heard of them and or participated in them in some way, shape, or form. So the first one that most of us have or are aware of is HMOs, or health maintenance organizations. It's a prepayment system where we pay into the system every single month or every single paycheck, and then the understanding is that whether we use services or not, we're going to continue to pay that monthly fee, whatever that monthly fee is. But then when we need services, we kind of have already essentially paid for it, and or somebody else has paid for it with us. But the whole reason that HMOs were formally established through the federal legislation was to kind of reorganize healthcare services and reduce the rate of healthcare cost increases so that we can control the utilization of the services that we were using. They are designed to provide care directed towards health promotion and disease prevention. This was kind of a new phenomenon, but the whole thing is that if we can prevent disease, we're going to save a lot of money in the long run. And we know, like I said, that there's a prepaid premium that each individual is responsible for. So that's HMOs. When you're talking about the different types, there's a couple of types of HMOs. You've got a staff model. And what I mean by staff model is that the physicians and nurse practitioners are actually employees of the HMO. Okay, so they work for Blue Cross Blue Shield or whatever the HMO is, United Healthcare, whatever. You don't see that as often anymore. There are certainly still those individuals, but they kind of have a different role. They're not necessarily direct patient caregivers. Then you've got the Independent Practice Association, and I see that we're kind of moving to IPAs a little bit more formal, more aggressively recently than we had. But this is where the healthcare providers maintain an individual or group practice, but they contract with the HMOs. So this is where sometimes your physicians come down to the aspect of having a contract with an HMO for 1 year, and so you may be able to go to a certain facility and or have certain procedures and or see certain specialists, but then depending on how that contract is renegotiated, those same things that were available last year are no longer available this year, and that's because those contracts are renegotiated every single year. Then you've got a group model. And a group model is when the HMO contracts with multi-specialty groups to provide the services for a negotiated fee. Kind of see that still today. And then you've got the network model. And the network model is really what we're probably most familiar with, especially those of us who worked in a hospital, because our HMOs through the hospitals are definitely a network. If you work for an SSM hospital, you are required within network to be utilizing SSM physicians. It makes sense that they would not be promoting the use of physicians outside of their own organization because they want to make sure that they are continuing the viability of their hospital system. So that's the network model. So within HMOs, you've got a couple of models like we talked about. The staff where they work for the actual HMOs, IPAs, which is that Independent Practice Association where the docs negotiate with different HMOs and stuff for the contracted services. And then the next one that you really need to be worried about is the network model where you've got the hospital-based SSM kind of aspect. Then the next kind of managed care we've got is PPOs, or preferred provider organizations. And this is really where incentives are given to the participants for selecting preferred providers, but they can go outside of that list of preferred providers. I know a lot of people who really like PPOs because it gives them more flexibility and more choice of who they're going to have care for them, both in the healthcare provider, the doc, whoever, as well as the facility in which they're going to go to. And then what's becoming a lot more common lately is going to be POS, or point of service. POSs are like an HMO in that you're required to choose a primary care provider from within the network, but you can choose outside of the network if you so care to. It's just going to cost you more money, but you can do it. And with POSs, there's typically deductibles. So this is where, depending on how you pay into your POS, will depend on the monetary amount of your deductible and your caps and things along those lines. But that's a POS. Something that is fairly new, that is starting to finally take off. I've actually been a part of this in some way, shape, or form for the past 10 to 15 years of discussion around this, but is physician hospital organizations. And this is a corporation that's formed between the hospital and the physicians for a joint purpose, where they will have joint ownership as well as joint ownership of the benefits and of the profits, but joint ownership of the costs. When I was working as a clinical director out at St. Joe Kirkwood about 10-15 years ago, the SSM had entered into an agreement with a group of physicians to build a women's hospital. and they were going to close the unit at St. Joe's as well as the OB unit at DePaul to get the beds as well as the dollars for this women's hospital. And it was great in theory. There was a couple of problems in how SSM went about obtaining the group of physicians that were politically problematic for them, and ultimately that venture died. But there's a group down by me, and really popular or prevalent in the Washington, Missouri area, but starting to come up to the Eureka area, where it's a joint venture like this, where the physicians have ownership. And I think I want to say First Watch, and I know that that's not the right name for it, but this is becoming more and more popular in our area, which it was thought at one point it was never going to make it, that doctors would never do it. But doctors are figuring out that they have a vested interest in making sure that they're working for a viable facility, as well as one that's going to be able to continue to be in operation because it's providing all the services, practice insurance and things like that. So some of the impacts that we've had, and I'm sure all of you guys have heard of horror stories or have been personally involved in some of the horror stories that have happened because managed care exists. But we know that in the 1990s, when there was rapid growth of the HMOs, that the quality of care that clients received suffered. It wasn't working the way it was intended to. We were making decisions for patient care based on financial reasons and not on the patient that was in front of us. And I think in so many ways that is probably the biggest problem, or the biggest curse of managed care, is that somewhere along the line we lost sight of the patient in front of us. And although there are certain aspects of trying to control costs, and there is definitely an argument made for that we do a lot of things needlessly, on a few of the patients where that test might have been needless, on 9 out of 10 patients, for 1 of the 10 it was needed, and it was integral in the care of that patient and the survivability of that patient. So it's not to say that all of the time we were doing these tests were they done without cause or without good reason. But when we got into this world of managed care, it became near impossible to do that test that might have been needed on that one person somewhere along the lines. So we need to somehow figure out how to balance this, because what's happened within the 90s and into the 2000s is that care decisions being more of a business decision instead of a healthcare decision. We've got stricter limits on health insurance plans and other types of services that will be covered by the health insurance. And ultimately, by doing that, we created these care pathways, which are wonderful tools to use for the generalized average patient with XYZ disease. But we need to realize that care pathways need to be individualized for the patient that's really in front of us. And unless we can do that, I cannot even begin to fix some of the issues that we've had with managed care. So we've had some laws that were passed to protect the clients to help prevent some of these issues that happened with managed care, but there still remains a huge need to decrease healthcare costs, and so it's still to be seen how these laws are truly going to affect the overall quality of care patients receive, while hopefully containing the costs that we're spending in healthcare. And nurses actually play a huge role within this entire process, because as a nurse, we are the ones who are at the bedside. We are the ones who are day in and day out, 24/7 with these patients. So we need to speak out and use our voice when we feel that a patient needs something and they're not able to get it, because there is ways to get it. It's just not always as easy as it should be. But conversely, if we feel that we are doing a whole bunch of needless tests and procedures on these patients just because we can, we also need to speak out and question the physician or whoever is the ordering individual about, why are we doing this? What's the purpose? What are we hoping to gain from this? One of the things that has come out with some of the negative aspects of managed care has been these healthcare report cards. And there's a lot of mixed feelings about this. I mean, in some ways, it's not a bad thing for the public to be aware when there is a physician who has a lot of malpractice suits against them or has been doing some questionable practices. But on the flip side, because we live in such a consumer-driven economy, there is a lot of physicians who do not do what they know they should do, what they firmly believe they should do, because this is such a consumer-driven society. What I'm meaning by that is that there are times a physician, let's go OB, since we know that that's the area that I know the best, inside, outside, upside down kind of aspect. There are some docs who are very good about not allowing a patient to bully them, and really it kind of is a bullying, into a needless C-section or an induction prior to when it might be deemed healthy for the patient and the baby. And the reason why they allow themselves to be bullied is that, especially in our area of St. Louis, we're OB saturated. If you don't like what your OB is saying or what your OB is doing, no problem. You just fire him and go find another one, and there's always another one who's willing to take your care. So when these physicians are trying to maintain a viable practice, which is dependent on having patients in that practice, they are allowing patients to potentially bully them into decisions that they would not normally make. So this report card aspect has a good part to it, but it also actually has a detrimental part to it too if we have physicians who are no longer doing what they need to do. The bottom line is, though, that in spite of the cost containment things we've done to try and contain costs, healthcare costs are still continuing to rise faster than any other segment of our nation's economy. And we're going to need to do something about it because we also, along with the healthcare costs increasing, we have more and more people who are uninsured, which is only going to further increase those costs. So this is obviously something that needs to be addressed. Who knows what it's going to be? And maybe one of you guys, as our new nurses in the future, will be able to have some kind of positive impact on this, because I know we've been kind of suffering and wallowing 20 years that I've been a nurse. All right, let's talk a little bit about Medicaid and Medicare. I'm obviously more familiar with Medicaid being OB, but Medicare is really what we're going to talk about because we know that this is one of the largest healthcare financing programs that we have. In 2003, that's how outdated this statistic is. So it's 8 years old. 2003, we know that we spent more than 277 million to 40 million, 270. $277 million on elderly care alone. Elderly and disabled. I shouldn't just say elderly. That is a huge amount of money. We know Medicare covers folks who are 65 and older and or who meet special criteria. And with Medicare, it's actually controlled by CMS, which is a Center for Medicare Medicaid Services. CMS actually drives many of our quality incentive programs within healthcare today, because if CMS opts to not cover a certain procedure, disease, whatever, let me tell you, the other private healthcare insurance companies will follow suit. So there are many things we do in a hospital that are driven by CMS services. Okay, we'll talk more about this as we go down the path, but just keep in mind that CMS is something that it's not technically an accrediting agency because they are the funders behind Medicaid and Medicare, but they are ones who control a lot of our practices within the hospital, because they're actually one of the ones who started some of the healthcare reporting, and they are the ones who made decisions like if a patient acquires a UTI while in the hospital, none of their care is covered while they're in the hospital. Not just care of the UTI, their entire hospitalization is not covered. So do you think we have a vested interest in making sure that we prevent hospital-acquired UTIs? And we all know we're talking about Foley usage, right? So that's now crossed over to other private healthcare insurance companies. So CMS is a big deal in the hospital world. But when we're talking about Medicare, there's 4 parts. You've got Part A, which is hospital insurance. And this is going to cover the skilled nursing if there's certain criteria that are met. The hospital admission needs to be at least 3 days, and that's 3 midnights, not counting the discharge date. So they need to be in a bed at midnight for 3 different dates for it to be covered. They will cover nursing home admissions, but it has to be for certain criteria. Like one of the things is that if you're going to be discharged from a hospital to a nursing home, the reason for the nursing home needs to be related to that hospital admission. There are other aspects that will play into when and where and how they'll cover a nursing home admission. Maximum length of stay is 100 days with this. The first 20 are paid for, but the last 80, there's a copay. So it's not entirely free, and there's certain fine print that families need to be aware of. And this is why we have services like case management that help us muddle through some of these aspects. Part B is the medical insurance. This is covering for a lot of the services that are not covered by Part A, and it's generally outpatient services like doctor's visits, nursing services, x-rays, labs, diagnostic tests, vaccines, those types of things. Things that you would think about going to your doctor for. That's the kind of stuff that's covered under Part B. And then Part C is the Medicare Advantage plans. This is really honestly private insurance. This is due to the passage of the Balanced Budget Act of '97 and the Modernization Act of 2003. And this ultimately allows there to be an option for Medicare recipients to have benefits through private health care insurances instead of just through the original Medicare plan. So this is something that we've heard a lot about within the past few years because it's become more and more prevalent, and they've had to figure out which one to pick and things along those lines. And then Part D is a prescription drug plan. This went into effect in January of 2006. You, as the individual, must enroll in this also. It's not an automatic. You need to actually physically enroll in this Part D to have your medications covered. At this point, it's not standardized. I anticipate that it probably will be. It's a good thing in many, many aspects. There are still many problems in it that we're continuing to iron out. So the first part of what I wanted to talk about. So I'm going to stop it here because I'm not sure why this slide is here, because we're going to talk about this on the next slide, on the next set of handouts.